Hi Ninja Nerds, in this video we're going to talk about the different types of hypoxia. So first off, what is hypoxia? How would you define hypoxia? Hypoxia, by simple definition, is basically inadequate oxygen delivery to the tissue cells. That's it. Hypoxia is defined as the inadequate oxygen delivery to the tissue cells. Let's write this down, and what I want to talk about is how would you identify certain signs? So if you're looking at a person, how would you know if they're actually in the early stages of hypoxia or the late stages of hypoxia? And then we'll go over the types of hypoxia. So first thing I said I want to discuss is what is the definition of hypoxia? And we already defined hypoxia. To keep it as simple as possible, hypoxia is low oxygen delivery or inadequate. So we can put low or inadequate oxygen delivery to tissues, regardless of what the tissue is. Okay, so whether it be the brain, which is a very, very vital organ, you always want to make sure that you're having an abundant supply of oxygen to the brain as well as the heart. Those are very vital organs, and even the skeletal muscles. But again, how would you define hypoxia? It is a low, inadequate, we don't need to put this around this, we can put it around inadequate. We can put a parentheses around inadequate. So low or inadequate oxygen delivery to the tissues. Okay, so now that we have the definition of hypoxia, the next thing that we want to say is, how would you determine if a person is actually exhibiting hypoxia? Well, it's hard to say because there's different stages of hypoxia. So within the early stages of hypoxia, so let's say, well, how would you determine if someone's in the early stages of hypoxia? So in the early stages of hypoxia, you can remember this little mnemonic. It goes RAT, okay? So you can remember RAT. And what does this stand for? R is specifically going to be for restlessness. So you're going to exhibit restlessness and certain agitation, right? A is going to be for anxiety. And remember, T is for two things, so there's two T's in this, right? So one is actually going to be tachycardia. So one's going to be tachycardia, and the other one's going to be tachypnea. The other one's going to be tachypnea. How would you define tachypnea? Tachypnea is basically an accelerated respiration process. That's all it is. So tachypnea is an accelerated respiration. Now, the next thing I want you guys to understand is how would you differentiate, because sometimes people can confuse tachypnea with hyperventilation or hyperpnea. Hyperventilation, let me define this for you so that way we don't get these confused. Hyperventilation is an excessive increase in pulmonary ventilation that exceeds the metabolic demands of the body, and it can change their blood chemistry. It can lead to respiratory alkalosis. Hyperpnea is an increase in the depth and the respiration rate. But it's usually in the sense of like exercise or even in painful stimuli, but it does not change their blood chemistry. And tachypnea is defined as accelerated respiration, okay? And then tachycardia, how would you define tachycardia? It's whenever their heart rate is greater than 100 beats per minute. So whenever their heart rate is greater than 100 beats per minute, okay? So these are the early signs. So you're gonna remember RAT, okay? And if you remember, the two T's are for tachycardia and tachypnea. What about the late stages when it's actually really bad? What about the late stages of this hypoxia? So some of the signs. And again, what are we trying to say here? This is the early signs of hypoxia. And then these are the late signs of hypoxia. And the reason why you want to be able to catch these things early, if it's possible, is to prevent these people from actually developing certain brain damage or damage to the heart as well. Okay, so again, what is the late signs? The late signs are going to be specific. Remember, bed, C. Remember, bed, C. B is going to be for specifically, so whenever you look at this one, B is going to be for bradycardia. Bradycardia. Oh, you might be like, whoa, what the heck? Their heart rate was eventually above 100 beats per minute, and then it switched to a decreased heart rate, to where the heart rate is now less than what? 60 beats per minute, okay? And then E is for extreme restlessness. So this is for extreme restless. And this. All right, so the D is for dyspnea. Okay? Now, the last one is going to be, I put C, right? So there's going to be C. And C is specifically going to be for, this is the bad one. When you recognize this is when you need to make sure that you alert the patient and try to take care of the patient as quickly as possible. This is cyanosis. And cyanosis means that there's actually a blue cast of the skin, right? So it's a bluish cast of the skin. That means that there's not enough oxygen delivery to the tissues. So again, hypoxia, how would you define it? Low, inadequate oxygen delivery to the tissues. The early signs is going to be, remember, RAT. So restlessness, anxiety, tachycardia, and tachypnea. And then remember the late signs of hypoxia, which you want to try to make sure that you treat the issue as soon as possible, is going to be bradycardia whenever the heart rate is less than 60 beats per minute. When they have extreme restlessness, they have dyspnea. What is dyspnea? Dyspnea is basically shortness of breath or gasping to bring in air. And the last one is cyanosis. And I'll talk about whenever you see these signs, how would you treat it? Because it depends upon what type of hypoxia they have. Okay, so that's hypoxia. Now the next thing I want to go over is I want to talk about specifically the 4 types of hypoxia. First, let's list off the 4 types of hypoxia. So the 4 types of hypoxia that I want to talk about in this video is going to be, we're going to talk about hypoxemic hypoxia. We're going to talk about another one, which is called ischemic. You know what's called ischemic? And they even call it stagnant. So they can call it ischemic hypoxia or stagnant hypoxia. And then there's the third one, which we're going to talk about, which is going to be anemic hypoxia. And the last one that we'll talk about is going to be histotoxic. Histotoxic hypoxia. Histotoxic hypoxia. Okay, so let's start off with the first one, which is usually the hardest one because it's the most in-depth one. This is going to be the hypoxemic hypoxia. All the rest of them are generally pretty easy, but we're going to start off with the hypoxemic hypoxia. It'll make all the rest of these a lot easier. So first thing I want you guys to remember about hypoxemic hypoxia is there's 3 things that you're going to see in hypoxemic hypoxia. 3 things. So what are those 3 things that you'll actually see in hypoxemic hypoxia? So in this, they can also call hypoxemic hypoxia, they call it hypoxemia. So we can also refer to it as hypoxemia, which again is hypoxemic hypoxia. There's 3 things that are going to be able to cause this hypoxemia. One thing that can cause this is actually going to be an alteration in the ventilation perfusion coupling. So any type of alteration in the ventilation perfusion coupling mechanisms, and we'll talk about that. Another one is going to be certain types of pulmonary diseases. So certain types of pulmonary diseases, specifically chronic obstructive pulmonary disorders and restrictive pulmonary disorders. And another thing that can actually cause hypoxemia, besides the ventilation perfusion coupling and the pulmonary diseases, any situation in which there is very little oxygen within the atmosphere. And that specific situation is at high altitudes. So when you're at high altitudes. So again, 3 situations that you would actually become apparent with an hypoxemia that causes it is any type of situation altering the ventilation perfusion coupling, any situation like a pulmonary disease, like chronic obstructive or even restrictive pulmonary diseases, or high altitudes. So let's start off with the easy one, high altitudes. How can this cause hypoxemic hypoxia? Well, when you're at sea level, generally, the pressure, the barometric pressure, so the pressure of the atmosphere, is approximately equal to about 760 millimeters of mercury. And out of that 760 millimeters of mercury, 21% of it is going to be the pressure of oxygen. So whenever you do this, you take 21% of this 760. This gives you about 160 millimeters of mercury of oxygen within the atmosphere. Okay? That is usually the partial pressure of oxygen in the atmosphere. So let's put here ATM. Now, as you go to higher altitudes, higher elevation, the percentage of oxygen decreases. So then look at this. The percentage of oxygen is actually going to decrease. So if the percentage of oxygen is going to decrease, it's going to become less than 21%. What's going to happen to the partial pressure of oxygen? It's going to be less than 160. So now the new partial pressure at high altitudes of the atmosphere is going to be less than 160 millimeters of mercury. So let's just suppose that whenever you're at high altitudes, you're hiking Mount McKinley, whatever you're doing, let's say it drops significantly. Let's say it drops from 160 to about, let's say it actually drops down to about 120 millimeters of mercury. So let's say it drops down really low, okay? So now out here, if the actual partial pressure of oxygen in the atmosphere is about 120 millimeters of mercury, and the partial pressure of oxygen in the lungs, what's the normal partial pressure of oxygen within the lungs? The normal partial pressure of oxygen in the lungs is generally about, what? 100 millimeters of mercury. So it's about 100 millimeters of mercury. So it's about 104, actually. If you want to be specific, it's about 104. So if you look at the difference here, 160 all the way down to 120. 160 to 100 is a 60 millimeter curve. 120 to 100 is a 20 millimeter curve. This is going to have very little oxygen. So the amount of oxygen getting down here into the alveoli is going to be a lot less. So what happens to the partial pressure of oxygen inside of this alveoli if the atmospheric oxygen is lower? It's going to be a lot lower. Not as much oxygen is going to be coming into the alveoli. And just imagine if this even drops below 100, then very little air will be coming in at all. So again, to recap this part here, whenever the partial pressure of oxygen in the atmosphere is less than 160 millimeters of mercury, and it drops down significantly, it decreases the actual movement of oxygen from the atmosphere into the alveoli, which is eventually going to cause a decrease in the partial pressure of oxygen. And this can actually lead to problems. And the reason why is, we'll discuss it in that diagram over there, if the partial pressure of oxygen is very, very low here, then what's going to happen to the actual exchange process within the actual blood? It's actually going to decrease within the blood, and that's going to be important. We'll talk about how that happens. So again, I used 120 as an example, but I want you to understand that if this sucker drops really, really low, depending upon how high the elevation is, to where it drops below 100 millimeters of mercury, let's just suppose 80 millimeters of mercury, what's the partial pressure of oxygen in the alveoli going to be? It's going to be 80 millimeters of mercury, and that's going to cause less oxygen to be delivered into the tissues, and that can lead to hypoxemia. Okay, what about certain pulmonary diseases? So chronic obstructive pulmonary disorder, they actually classify asthma to be one of those types, and there's actually chronic bronchitis and emphysema. So in certain situations, let's say that we take chronic bronchitis, and so in chronic bronchitis, there's an excessive amount of mucus production, and look what it's doing to these actual bronchioles. It's decreasing the amount of air that's getting into this bronchiole. If you decrease the amount of air getting into these bronchioles, what's going to happen to the ventilation within this alveoli? It's going to decrease. So what happens to the partial pressure of oxygen within the alveoli? It decreases. So there's going to be a decrease in the partial pressure of oxygen. So that could be in chronic bronchitis. Well, how would asthma cause this? Asthma is basically generalized and widespread bronchoconstriction. So if I constrict the bronchi, if I have an excessive constriction of the bronchi, what's going to happen to the air going to the alveoli? So let's say that, for example, I actually start trying to constrict this bronchi. I'm having some type of allergic reaction or something like that. I'm having an asthmatic attack. And I have severe bronchospasms. And those bronchospasms are constricting the actual bronchi and decreasing the amount of air going to the alveoli. What's going to happen to the partial pressure of oxygen? It's going to decrease. Okay? What about another pulmonary disease? We said emphysema. What is emphysema classified as? How would you classify emphysema? Emphysema is basically a situation in which, how we have our normal alveoli here? Let's say that I draw a general diagram of the alveoli. So let's say here's the alveoli. They have a large surface area, right? So there's my diagram there. And again, what's coming around these guys? What do you have around them? You know that you're going to have a lot of blood vessels, right? Here's going to be a lot of blood vessels. And what happens in emphysema is your neutrophils start producing excessive amounts of elastase. Because remember, there's an alpha-1 antitrypsin deficiency. And what starts happening? It starts breaking up the actual septal walls that are consisting of the nice elastic tissue. And then what does it eventually do to the actual alveoli? It makes it one big alveolar chamber. And then when you have just one big alveolar chamber with not very many septa, what happens to the actual surface area? It decreases. If the surface area decreases, what happens to the gas exchange process? That also decreases. So, but specifically, remember this though, it's not a problem with this because in emphysema, generally, these people have a normal partial pressure of oxygen, generally. So in this situation, in emphysema, they can have a normal, we shouldn't put increase, we should have a normal, they can have a normal partial pressure of oxygen, and that partial pressure of oxygen can be about 100 millimeters of mercury. And again, if you want to be specific, it could be 104, but they're not having a problem with getting air in. they're having a problem with the exchange process because, again, what's happening? They have a lot less, what is this condition? This is called emphysema. And in emphysema, what happens to their surface area? What's the overall result? What happens to the surface area? There is a decrease in the surface area. What does that mean? That means there's going to be a decrease in the exchange process. So there's not going to be as much what? There's not going to be as much CO2 moving over here and not as much oxygen moving into the blood. And so if there's not as much oxygen moving into the blood, what happens to the partial pressure of oxygen within the blood? It decreases, and that's hypoxemia. Okay, and then we'll talk about one more pulmonary disease. Okay, let's say that for some situation you have, you get stabbed. And there's some type of situation where the actual atmospheric pressure, the atmosphere, air, is exposed into this actual pleural cavity. What can happen? You know, air can actually flow right in because the pressure in the atmosphere is what? The atmospheric pressure is approximately 760 millimeters of mercury. What is the partial pressure in the actual pleural cavity? Do you guys remember? The pressure within the intrapleural cavity was approximately 756, or we said -4 if you guys remember, right? But in either way, it's a less pressure. So where is air going to want to move? It's going to want to move into this actual pleural cavity. What did we say that would do over time? Look at this. Let's say I erase this partial pressure of oxygen here. Look at this. As this pressure starts increasing, so it goes from 756 eventually to what? If you guys remember. It eventually can equilibrate with the atmosphere. And if it equilibrates with the atmosphere and it actually rises up to the point of 760 or even maybe above 760 millimeter of mercury, what's it going to start doing? It's going to start pushing on the lungs. As it starts pushing on the lungs, look what happens here. Let's say I actually depress in these lungs here. Look at this. If I have this little cavity here now, what am I going to do to all the small alveoli that I'm compressing? I'm going to be decreasing the actual, what am I going to do? I'm going to be collapsing the alveoli. So whenever I have an increased intrapleural pressure, whether it be to air leaking in, what is that called when air leaks into the actual pleural cavity? What do you call that? You call this a pneumothorax. So in some situation in which there's actually air, you can develop a pneumothorax. You know, there's other situations besides air. If there's actually a rupture of the blood vessels within this area and the blood accumulates within this actual intrapleural space, what do they call that when blood's accumulating? They call that a hemothorax. And there's even more. If you actually have lymphoma, there can be a blockage of the actual lymphatic vessels and it can lead to a lot of the lymph draining into this area, and they call that chylothorax. Either way, the whole important point here is that as this fluid starts accumulating, what does it start doing? It starts pushing on the lungs. As it starts pushing on the lungs, what is it going to do to the alveoli? It's going to collapse the alveoli. If this, let's imagine here's this alveoli, it was previously inflated, but then because of the pneumothorax or the hemothorax or the chylothorax, it collapses. So now look at it. Look at it. It collapsed. The balloon pops, right? So it collapsed. If that sucker collapsed, what's going to happen to the ventilation within that? There's going to be no ventilation. If there is no ventilation to this area and there's blood vessels passing by this area, so let's say here's a blood vessel coming past this area. Here's a blood vessel, and it's looking to pick up some oxygen. If this sucker right here pops, right, or collapses in this situation because of the increased pressure, because of the pneumothorax or hemothorax or chylothorax, it's pushing on it. Is there going to be any ventilation? No. So if there is extremely low ventilation or almost no ventilation, there will be no exchange. If there is no exchange that's occurring between these the alveoli and the actual pulmonary capillary blood, what is that called? It's called shunting. So this is an example of shunting. Okay, so I want you guys to understand again, one more time. If you have chronic bronchitis, it's going to impede the actual airflow, decrease the partial pressure of oxygen. Also with asthma, it's actually going to cause widespread and generalized bronchoconstriction, which will decrease the air getting into the alveoli. That'll also cause a decrease in the partial pressure of oxygen. If you're at high altitudes, the partial pressure of oxygen in the atmosphere is going to be a lot lower. It can actually drop below 160. And if it gets really, really low, below 100, let's say, suppose we said 80 millimeters of mercury, then the partial pressure in the atmosphere, when it actually exchanges with the alveoli, it's going to drop significantly, and it can drop all the way down, right, inside the alveoli. And let's just say that it drops down to like 70 or 80 millimeter mercury in the alveoli. That can actually impede the exchange process and cause a decreased partial pressure of oxygen within the blood. Then we also said in emphysema. In emphysema, there's a decrease in surface area due to the breaking down of the elastic fibers in the walls, and that decreases the exchange process. But remember, they have a normal alveolar partial pressure of oxygen. It's the diffusion process that's actually affected. There's another situation that can affect this also. If you have pneumonia or you have pulmonary edema due to the heart failure, right? What happens to the fluid that accumulates in between these spaces, these interstitial spaces? It spreads out the actual respiratory membrane. The thicker that respiratory membrane, what's it going to do to the actual exchange process? It's going to decrease the exchange process. So again, not only can emphysema affect the actual exchange process, but what other two conditions can? Pulmonary edema, as well as, we said, pneumonia. And pneumonia can actually produce a pyothorax, which is really nasty. It's pus that accumulates within this cavity too, which can also compress. And that was the last thing. Whenever there's air, blood, lymph, or even pus that accumulates within this area, it compresses on the lungs and actually does what? It collapses the alveoli. If these alveoli are receiving no air, they're going to be not ventilated. And whenever there is no, so look at this. I'm going to represent it like this. If there is no movement of CO2 in here, or there's no movement of oxygen there. So now look, if there's none of this, this action is inhibited. There is no ventilation, there is no actual exchange process that is called shunting. All of these things are trying to do what? What is the overall result of hypoxemia? It's trying to decrease the arterial partial pressure of oxygen. Okay? So now that we've covered that, we honestly should understand now, for the most part, right, how this whole thing is actually this what is this again? What was this first one that we talked about mainly? Hypoxemic. Hypoxia. How this is actually occurring be due to any type of ventilation, perfusion coupling, mismatch, or high altitudes, or pulmonary diseases that we covered. If you really honestly want to know if the diaphragm is damaged, the external intercostals are damaged, or even the nerves that are supplying them that we talked about. Remember the T1 through T11 and the C through C5 nerve roots that are supplying the actual diaphragm, the external intercostals. If they are damaged, that can also produce this actual hypoxemic hypoxia, but that's really bad. Or even if there's damage to the respiratory centers within the medulla, like the VRG or the DRG, right? Anyway, that covers that concept. Okay, so now we covered hypoxemic hypoxia. Now let's go into the next one, because these two are going to kind of link together. It's going to help us to really understand hypoxemic and ischemic. So let's go over to this big diagram, okay? So now, again, in hypoxemic hypoxia, what were the two issues? It was either one issue was that there was a decreased partial pressure of oxygen within the alveoli, or the exchange membrane was thickened. Let's do that in a nice, this color right here, this due to brown color here. This actual exchange membrane is thickened. If the exchange membrane is thickened, what does that do to the actual gas exchange process? This will actually impede the gas exchange. So there'll be a decrease in exchange of gases. And this was by emphysema or pneumonia, or even what else did we say? We also said due to pulmonary edema, maybe due to congestive heart failure. And this decreased partial pressure of oxygen could have been due to chronic bronchitis, could have been due to asthma, could be due to being at high altitudes. We already get the point now, all right? And again, what's the whole purpose here? We said the two things. If the partial pressure of oxygen decreases, let's just pick a number. I'm not saying it will be this, I'm just picking a number. Let's say that the partial pressure of oxygen in the alveoli equals 60 millimeters of mercury, right? What is the partial pressure of oxygen going to the lungs in the actual pulmonary artery blood? It should be approximately, if you guys remember, 40 millimeters of mercury. And then when it's moving through the actual capillary blood, what happens? It should have its exchange process. And whenever there's the exchange process between what? The actual alveoli in the blood, oxygen will move down its concentration gradient until the actual partial pressure in the pulmonary capillary blood equals the partial pressure in the alveoli, which is 60. So when it leaves, it should leave at partial pressure of oxygen is equal to 60 millimeter mercury. And again, what did we say is the normal partial pressure of oxygen within the arterial blood? So we'll put here right below it the normal one so we can compare. Usually it's about 100 millimeters of mercury. So this is normal. This is abnormal. Okay, we'll put AB. All right, so that's what I want you guys to get, whether it be due to some decreased partial pressure of oxygen in the alveoli due to all the reasons we discussed, or because the exchange membrane is so thick or the surface area is decreasing that the exchanges of gases isn't occurring efficiently, and that's also decreasing the arterial partial pressure of oxygen. All right, we beat the dead horse with that one. Let's move on. Okay, so let's say now your arterial partial pressure of oxygen, let's assume that it's perfect. So let's assume that you're coming down here. We're taking a whole new person. That person was someone else. All right, he was all the way fricked up. But now we're going to say, let's say that someone has a good partial pressure of oxygen. So their partial pressure of oxygen is 100 millimeters of mercury. They're rolling, okay? They're coming and they're delivering this blood to their capillary beds, right? So the blood is coming through here, okay? And it's coming in at what? It's coming in at a partial pressure of oxygen at 100 millimeters of mercury. Good oxygen supply. Oh boy, but look what happens to this guy. This poor guy, he's been eating too many Big Macs. And he has a lot of atherosclerotic plaques or thrombi that is accumulating in this area. And he has all of this actual plaque and occlusion to this actual blood vessel. What's going to happen to the amount of blood getting through this area? Because of him pounding down Big Macs and quarter pounders. What's going to happen? Very little blood is going to get by. If very little blood is going to get by, what's going to happen? What is the structures that are carrying the actual oxygen? Hemoglobin. What is hemoglobin carried in? Red blood cells. So if you guys remember here, look, here's my actual red blood cell here. And again, who is the actual structure inside of my red blood cell that's holding on to that oxygen? Hemoglobin, right? And if you remember, hemoglobin can actually bind onto 4 oxygen molecules. Now, if there is very few red blood cells coming to this area because there's an occlusion, what happens to the oxygen delivery to the tissues? It decreases. What is that called? Hypoxia. So again, in this situation, the oxygen delivery to the tissues is actually going to decrease. So there's going to be a decreased oxygen delivery. Okay, so again, one more time with this one. What is this one called here? So that we write this one down. This one here is the second one that we talked about. This is called ischemic hypoxia. And again, what is another name for it, just in case? You can call it stagnant hypoxia. Okay, so again, in this situation, there's a thrombus or an embolus or something like that that is occluding a blood vessel and decreasing the amount of blood going to the capillaries. If you decrease the amount of blood going to the capillaries, you decrease the actual amount of red blood cells going to this area. If you decrease the amount of red blood cells, that decreases the actual oxygen delivery, okay? So again, in this situation, there is very little red blood cells in this area. That is not anemia. Do not confuse this. I am not writing this here. Let me actually write this here. Very little red blood cells in the vicinity, in capillary. Okay? I'm not talking about anemia. That is a different type of hypoxia. I'm just saying that there's not a lot of red blood cells in this area because there is a thrombus impeding the amount of red blood cells coming to the area. So it's a decreased oxygen delivery, and that results in hypoxia. Whoo, all right. What else? You know, there's another situation. Same guy, you know, he's been putting down the Big Macs like it's going out of style, and the double quarter pounders with cheese. Those are so delicious. But anyway, we come back to this, and he's look what's happening here. He has congestive heart failure, and his heart muscle has become very weak. And so in congestive heart failure, what's the whole problem? Their heart is not strong enough to be able to pump blood from this is the left ventricle here, right? Because if this is the left ventricle, this would be the right ventricle. Okay, and this is the right atrium, and this is the left atrium. This is the aorta, right? So in congestive heart failure, what happens? Their actual cardiac output decreases. What is cardiac output? Cardiac output is defined as the heart rate multiplied by the stroke volume, right? So if they have a decrease in cardiac output, then they're not going to have a lot of volume of blood coming to this area. So what happens to the volume of blood being distributed? What's normal cardiac output? So cardiac output's normal is about 5 liters. Okay, so 5 liters per minute. Their cardiac output is actually going to be less than this. So they'll have less than 5 liters per minute. Now, if you think about that, if they have very little blood coming to this actual same capillary bed, very little blood. If they don't have a lot of blood coming to this capillary bed, what is it going to mean then? Isn't it going to mimic the same thing? That there's not going to be a lot of blood coming to this area. If there's not a lot of blood coming to this area, doesn't that mean there's not going to be a lot of red blood cells? Doesn't that mean that there's not going to be a lot of oxygen delivery? And doesn't that mean that they'll produce hypoxia? Yes. Okay, so in this situation, in congestive heart failure due to a decrease in cardiac output, this is due to a decreased blood volume delivery or supply to tissues. Okay, so it can mimic this actual ischemic hypoxia. And again, this is due to more of a stagnant because it's going to have this very slow flow. You're not going to have a lot of blood coming to this actual area. Very, very little blood coming to this area. Okay? Okay, so again, what have we talked about so far? So far we've done, what was this one here, guys? This one up here that we discussed was the first one. This was called hypoxemic hypoxia. And then we've talked about ischemic hypoxia, or we've talked about, or we can call it stagnant hypoxia, which is due to congestive heart failure, or due to some type of thrombus, or maybe even a vascular tumor of some form. It's basically impeding the blood flow. And the blood flow through this area is very, very, very slow. Very little red blood cells coming to the area, very little oxygen delivery, and hypoxia. Okay, now let's do the third one. The third one is anemic hypoxia. Okay, so the third one that we're going to talk about here is going to be called anemic hypoxia. So in anemic hypoxia, it's very simple. It's honestly very simple. We've already had a video on anemias if you guys have already watched it. And if you guys remember, inside of the actual bone marrow, what do you have? You have the myeloid stem cell. So we'll put MSC. And if you guys remember, the myeloid stem cell was dividing, right? It was forming a lymphoid stem cell and then a myeloid stem cell. So we had specifically the, actually you should call this not a myeloid stem cell, you should call this actually a pluripotent stem cell, the hemocytoblast. And it was actually dividing and forming lymphoid stem cells and myeloid stem cells. And the myeloid stem cells were actually looking to form the red blood cells. Well, in some situation, and whether there is actually a decreased number of red blood cells, what could cause a decreased number of red blood cells? Certain types of anemia. This could be maybe in certain situations when there's very little red blood cells being produced, maybe aplastic anemia. Could be due to aplastic anemia. Another thing that could actually cause decreased red blood cells to actually be present besides aplastic anemia is actually them getting lysed. And if they're getting lysed consistently, that can decrease the amount of them present. So maybe even in hemolytic anemias. Okay, what about a situation where it's not about the number of red blood cells? What if the hemoglobin isn't appropriate or isn't normal amount of hemoglobin inside of the red blood cells? So let's say that it's not just specifically the actual low red blood cells. Let's say it's another issue, and let's say that you have abnormal hemoglobin. Well, why is that important? Because hemoglobin is responsible for carrying oxygen. So if there's an abnormal hemoglobin, that's going to affect the oxygen carrying capacity. Right? So in certain situations like this, what could this be due to? This could be due to a specific situation like microcytic anemias, like iron deficiency. So it could be due to iron deficiency. It could be due to B12 deficiencies. It could be due to many different things. It could even be due to thalassemia. And it can even be due to sickle cell anemia. So you guys should get the point, right? So again, in certain situations in which there is anemia, whether it be due to very little red blood cells being produced, in which there is an aplastic anemia, in other words, if you guys remember, there's damage to the myeloid stem cell in this case, it won't be able to produce enough red blood cells. Or if there's hemolytic anemias to where there's spherocytosis or G6PD-H deficiencies or whatever the situation might be and it gets stuck in the capillaries and they get destroyed, that can decrease the number of red blood cells. Or if their hemoglobin is actually abnormal, like an iron deficiency, B12 deficiency, folic acid deficiency, thalassemia, or sickle cell anemia. You guys get the point. Why am I stressing this? I want to make a quick point of how crazy this is. Okay, in one red blood cell, this is insane. In one red blood cell, you have 250 million hemoglobin molecules. And one hemoglobin molecule can actually bind 4 oxygen molecules. That means in one red blood cell that consists of 250 hemoglobin molecules, what is 250 million times 4? 1 billion. 1 billion oxygen molecules. For what? For one red blood cell. Isn't that insane? So because of that, I just want you guys to get the point that if there is any situation in which there's what? A decrease in the number of red blood cells, or a decrease in the actual, not a decrease in hemoglobin, or decrease in hemoglobin or abnormal hemoglobin, it could significantly affect the amount of oxygen molecules that are bound. And if this red blood cell, for example, let's say that I have this red blood cell. I'm going to expand this capillary a little bit. Let me expand this capillary a little bit so you guys can see here. So let me grab my blue marker here, and I'm going to expand this capillary just a little bit more here. And I want you guys to understand here, let's say that now I don't have a lot of red blood cells. So I have a decreased number of red blood cells. Or the red blood cells that I do have are actually having abnormal or deficient hemoglobin. What does that mean? That means very little oxygen delivery. And if there is very little oxygen delivery, what does that produce? Hypoxia. Okay, so that should be clear now. Okay, so far we covered hypoxemic hypoxia, we covered ischemic hypoxia, and then we talked about this third one, which was anemic hypoxia, which could be due to a decrease in the number of red blood cells like aplastic anemia or hemolytic anemias, or it could be due to deficient or abnormal hemoglobin such as an iron deficiency, B12 deficiency, thalassemia, and sickle cell. So in thalassemia and sickle cell it would be abnormal hemoglobin, and iron and B12 would be more of a deficiency in the actual functional hemoglobin. Okay, now that we've done that, I have one more that we need to talk about. And I want to talk about how you would actually be able to treat these situations very efficiently to make sure that the patient doesn't die. Okay, so the last one is called histotoxic hypoxia. So again, the last one is called histotoxic hypoxia. So this one is it's really interesting. You could have a normal partial pressure of oxygen all day. You could have greater than 100 partial pressure of oxygen. It wouldn't matter. Inside of your actual cells, you have a specialized structure. Look at this structure here. You guys should already know this structure. This is called your mitochondria. And your mitochondria are responsible for what? You know, your mitochondria are specifically responsible for being able to take oxygen, and they basically accept the electrons. They put the electrons onto the oxygen to form water and to make ATP. In a certain situation in which someone, for whatever reason, has cyanide. Cn negative is cyanide. For whatever reason, they get poisoned with cyanide. Cyanide affects a specific component of the electron transport chain. There's what's called complex 4 or cytochrome oxidase. It inhibits this enzyme. And this enzyme is responsible for doing what? It's responsible for taking the electrons from the electron transport chain. If you guys remember from our electron transport chain video, it's cytochrome A plus A3 who drops the actual electrons onto oxygen. So it takes the electrons and it adds it onto oxygen to form water. Well, if there's very little oxygen, there's going to be very little actually electron accepting. And if that's the case, what's going to happen then? Even though oxygen is in abundant amounts, this enzyme is inhibited. And if this enzyme is inhibited, it cannot pass the electrons onto oxygen. So what happens? Oxygen does not get utilized. If oxygen isn't utilized, can you produce ATP in this cell? No. And the ATP levels plummet. Same thing with this one. ATP levels plummet, and same thing with this one. ATP levels will plummet. Okay? So even though you could have abundant amounts of oxygen, but it would not matter because their cytochrome oxidase is being inhibited by the cyanide. It's binding to it very strongly and preventing the electrons from being added onto oxygen, so it's not being utilized and ATP is not being made. Why is it so bad to have hypoxia for such a long period of time? Because if a tissue goes for a while, what I told you, two main tissues I want you guys to please remember: brain and the heart, at least. If these tissues go for a long period of time without oxygen, what can happen? They can become hypoxic, we already know that. But then it can lead to ischemia. Decreased oxygen supply, very, very significant. And then it can lead to, unfortunately, necrosis, which is reversible cell death, right? And if that cell dies, if you have neurons are amitotic, so if they're damaged, they aren't coming back. Heart muscle, same thing. So it's very, very important, it's very vital that we get as much oxygen to the important vital tissues as possible. Okay, so now that we talked about this, I want to talk about one more thing. I want to talk about specifically how you would be able to treat these patients, because it's not all the same. You can probably just say, oh, give them supplemental oxygen. It's not going to work for all of them. One last thing I wanted to mention I forgot to talk about was this shunting thing, right? I talked about it here whenever there's complete lung collapse. There's one more thing, and it's unfortunate. It's in a condition called tardive cyanosis. Okay, they call it tardive cyanosis. Okay? And in tardive cyanosis, what happens is it's a congenital heart disease. And in the congenital heart disease, the ventricles, the septal part, does not form completely. And it actually develops a septal defect. So they develop specifically a ventricular septal defect. What happens is, this is your left ventricle. This is your right ventricle. Usually the left ventricle is a more powerful pump, so it contracts harder, right? And what it does is, over time, it'll push some of this blood. What kind of blood is over here in the left ventricle? High amounts of oxygen. Oxygenated blood, very high. What about the actual blood over here in the actual right ventricle? Low oxygen. That's why it has to go to the lungs, because it has to go to the lungs to get oxygenated and come back to the left atrium, which are actually going to be oxygen delivered to the tissues. What happens is, when the baby is actually having this condition, a lot of the blood is being shunted from the left ventricle to the right ventricle. But then what happens to the amount of blood that's being pumped from the right ventricle to the lungs? It increases the actual blood volume. What does that mean? This right side of the heart's going to have to pump a lot harder. So it pumps a lot harder. And actually what happens is, eventually it hypertrophies. And whenever a muscle like this hypertrophies, so if this muscle right here has consistent contractions, it will hypertrophy. Hypertrophy. And whenever this muscle hypertrophies, eventually actually is going to become very strong. And when it becomes very strong, guess what happens? The blood starts flowing in the opposite direction. And then when it starts flowing into the opposite direction, blood is flowing from the right ventricle into the left ventricle. And what blood is coming over here? Low oxygen. And what would happen to the normal? Let's pretend that here inside of this actual left ventricle, the partial pressure of oxygen is 100 millimeters of mercury. And some of this deoxygenated blood comes over here. And over time, when it leaves and goes out into the systemic circulation, it actually drops down, let's suppose, to about 80 millimeters of. So again, in this situation in which the partial pressure of oxygen is actually decreasing because some of the blood, the deoxygenated blood from the right ventricle is being pumped over here into the left ventricle, and it's leaving out with a little bit deoxygenated blood, what's going to happen then? The partial pressure of oxygen is actually going to decrease. And what's it called when the reduction of partial pressure of oxygen is on the arterial side? It's called hypoxemic hypoxia. There is one last one. I'm not going to spend a lot of time on it. It's whenever you have carbon monoxide poisoning. Carbon monoxide poisoning is actually a situation, very deadly. Happens a lot when there's fires. But in situations like that, carbon monoxide poisoning is actually specifically considered to be a unique type of hypoxemic hypoxia. And what it does is if I had the hemoglobin right here, here's my hemoglobin, and you know how oxygen wants to bind to the actual hemoglobin? What happens is, in people who have carbon monoxide poisoning, carbon monoxide actually binds to that site because it has 200 times more affinity than the oxygen. And if that's the case, then if you have carbon monoxide poisoning, you could actually have this bind onto oxygen. It doesn't matter how much oxygen you have. It's actually going to be specifically blocking that oxygen. And then when it blocks the oxygen, it prevents the oxygen from being able to bind, and hemoglobin is delivering this carbon monoxide. And it can actually produce a very dangerous hypoxia because you wouldn't even know that you're actually having carbon monoxide poisoning. Okay, you would just develop some type of, you'd turn cherry red, you'd have like a disorientation, be a little bit confused. But again, very deadly. How would you treat this one? You give them a lot of oxygen. As much oxygen as you possibly can. Put them in a hyperbaric oxygen chamber and give them high pressure oxygen. And the reason why is, if you give them exceedingly amounts of oxygen, it can competitively outbeat the carbon monoxide. And whenever it actually competitively outbeats the carbon monoxide, it can then rebind, okay? Okay, how do you treat people with hypoxemic hypoxia? Well, in all those situations, usually you're going to want to be able to give them supplemental oxygen. So give them supplemental oxygen. So in treating hypoxemic hypoxia, one of the best things to do is give them supplemental oxygen. Be very careful when you're giving supplemental oxygen to people with chronic obstructive pulmonary diseases. Because if you give them too much, it can actually put them into respiratory arrest. Okay, we'll talk about that when we talk about chemoreceptors. Ischemic or stagnant hypoxia. Well, if they have this condition over here, let's come over here really quickly. If they have ischemic hypoxia, what are you going to want to do? Give them some type of, basically a clot busting drug. So give them tissue plasminogen activator, or give them warfarin, or give them aspirin, or give them some type of drug that's actually going to rid the clot, or do a surgery. So whether it be TPA, whether it be warfarin, or whether it even be surgery to remove the clot. What about congestive heart failure? In congestive heart failure, you have to be able to take care of the issue. So in this case, you're going to want to give them digoxin. And digoxin is going to try to stimulate the actual inotropic agent and increase the contractility of the heart. But with people who do have congestive heart failure, you can help them a little bit if you do give them supplemental oxygen. It can make a small difference in the actual congestive heart failure. It can be the difference between life and death in these patients. Okay, what about histotoxic hypoxia? Whenever you have cyanide poisoning, if you give them supplemental oxygen, it's not going to do anything because it doesn't matter how much oxygen you have. It's because the actual cyanide is actually inhibiting the cytochromes. So you have to give them some type of drug. So usually they give them a derivative of vitamin B12. They call it hydroxycobalamin. You can give them that, or you can give them what's called sodium thiosulfate with nitrites. And that can also get rid of this actual cyanide poisoning. Okay, and if they have anemic hypoxia, obviously you have to treat the anemia, because in these individuals in anemic hypoxia, they could have a normal partial pressure of oxygen. But again, you have to treat the anemia. So in this type of situation, you might have to do blood transfusions, depending upon what type of anemia it is. It all depends, right? But in general, you could give them supplemental oxygen. So if you give them supplemental oxygen, it actually can make a small difference because it can actually increase the amount of dissolved oxygen within the blood. That can give them just a little bit more oxygen that they need to be able to get through that issue. All right. All right, engineers, so in this video, we talked about the different types of hypoxia and the different types of clinical correlations and signs that you would see in these individuals. I hope all of it made sense. I really do. I thank you guys for sticking in there with me throughout this video. If you guys enjoyed this video, please hit the like button, subscribe, comment down in the comment section. As always, Ninja Nerds, until next time.